Mike's got just to focus our minds, Mike's got a typical case here. So this is a frail patient who Mike saw in his clinic who he thought looked pretty dodgy, and if he thinks somebody looks pretty dodgy, I think that's probably true. Emphysema, angina, borderline but not terrible pulmonary function test, but the guy looked bad when you saw him in clinic. CT scan showing a likely or biopsy-proven tumour in the periphery of the right upper lobe. Question is, what should we do? Shireen, do you know where your slides are?
Okay. Oh goodness, I'm moving this around. That's not good, is it? Let's go back. Right, slideshow. Yeah. From the beginning.
Is this your presentation?
Mm-hmm. Enabled, you have to enable it. I think it's, yeah, it's because I've got a dodgy movie on there.
Do you look at the radiotherapy as free?
No.
How do you do this now? I've forgotten how to do this now, actually.
That's red rag to a bull.
I can't remember how you get rid of this bloody thing now.
What's that? Try it. If you've tried enabling, it's because of this movie.
Yeah. Show of hands, who works in a
Shall we just close it down? Try and close it down.
Radiation is
Let me close it down either. Then why? I've forgotten how we did it before.
It's there. Oh yeah, that's it.
That's the one, isn't it? So,
Try going to that one.
40 minutes ago it worked.
why won't it let me do it now? I don't know why wouldn't it be.
Perhaps you could act out your slides for us.
Yeah.
So, we changed it before, but I can't remember who did it now. Oh, this is embarrassing. Won't let me do anything, will it?
Here we are. Do you think it'll work?
Try that and try that on them.
Yeah. Oh, that's good. Right. Okay. Thank you. So, thank you to Mike and Tom for inviting me to speak today, and I'm going to. Sorry, what?
You showed a blue lightsaber.
I know. Well, I trawled the internet to find a blue lightsaber, but couldn't find one, sadly. So, stereoablative radiotherapy, or SABR, and I would argue that this may be the new weapon against lung cancer. And I think what you'll find in this talk is that clinical oncologists, as we are, we're quite geeky people. We like new gadgets and toys, and I apologise for the sci-fi theme that will continue. Right. Perhaps continue. Let's try again. Oh. Now my friend's gone. Shall I end show? Try again?
Isn't. Do you just want to go to the next one?
Yeah. Okay. Right. So, as we've heard, stage one non-small cell lung cancer has traditionally been treated with surgery, and surgical resection remains the standard therapy, with approximately a 70% 5-year survival. With conventional external beam radiotherapy, you're looking at much lower figures than that, surviving at 5 years. And I think that certainly stereoablative radiotherapy, or SBRT, it's exactly the same thing, so I'll use them interchangeably through the talk. Offers a promising non-invasive alternative to certainly conventional external beam radiotherapy, and perhaps even to surgery. I mean, I'll tell you my position at present is that I don't think it's an alternative to surgery. I think it is certainly an alternative to conventional radiotherapy, and we should be offering it to all patients. Whether it's an alternative to surgery remains to be seen, and I think the trials are being done, and we will know soon in the future. So what I'm going to do is, my impression is that probably not a lot of you know about stereoablative radiotherapy, so I'm going to talk to you about what it is and how it's different to conventional radiotherapy. A little bit about the literature, but I think my surgical colleague is going to talk about the literature a little bit more, so I'll leave that to him. So the principles of SABR, what we do is we use multiple coplanar and non-coplanar beams in a fan-like distribution around the whole patient. So with conventional radiotherapy, we tend to concentrate on the lung where the tumour is, and very much concentrate on that side. But with SABR, we have beams of radiation around the whole patient, each giving a very small contribution, and that enables you to have a very high dose at the centre where the tumour is, and actually a very low dose to all the normal tissue structures surrounding the tumour. We also have this concept of biological effective dose, or BED, that we use in radiation oncology, and with SABR, the BED is much higher than with conventional radiotherapy. So we're looking at doses of 100 gray. With conventional radiotherapy, we're looking at doses between 60 and 66 gray, so significantly higher. The dose per fraction is also higher than with conventional radiotherapy, and Dr. Maguire also has talked about tumour repopulation, and that is something that we can avoid if we can finish the treatment in the shortest possible time. And the way that we do this is by more precise planning in order to achieve maximum dose plan conformality, and I'll show you some pictures later on to illustrate that. So here's some clinical trial evidence on SBRT. So this is trials going back 10 years. SBRT started in Japan, actually. The Japanese pioneered this treatment, and then you can see that later on there are some data from Europe and also the States. And I want to show you the local control rate. You can see it's very good. I mean, the median follow-up here is modest, but you're looking at local control rates in the range of 85 to 95% with this treatment. So what we do at Guy's and Thomas's is we treat patients with T1, T2, N0 tumours, and they are medically inoperable but fit for radical radiotherapy. Tumour size less than 5 centimetres, and we exclude central tumours. So we have this region that we've defined, the no-fly zone, which is illustrated here. So what we do is we outline the proximal trachea, right and left main bronchi, and their first divisions, then put a 2 centimetre margin around that, and that's the no-fly zone. And the reason is because if we treat tumours in this area, there have been case reports of catastrophic results. So you may be in danger of causing an aortic blowout or tracheobronchial fistulae. I think actually, as long as you get the dose fractionation right, it is safe to treat central tumours. But the patients that I was alluding to were treated with very high doses of radiation with, so the 18 gray times 3 that I've got down at the bottom there. But if you have a lower dose over a slightly longer period of time, I think it is safe to treat the central tumours. And that's something that we're looking at in clinical trials at the moment. But down at the bottom there are the fractionations that are most commonly used in this country for stereoablative radiotherapy. So one of the challenges that we have with SABR is that we need a mechanism to accurately assess tumour and lung motion. And again, this is what Dr. Maguire was talking about, and I think it's something that in radiation oncology we are very interested in, and there's been a lot of work that's been done over this over the last 4 or 5 years. And the way that we do this is with 4D CT scanning, 4D CT radiotherapy. And what's 4D, I hear you cry? Well, can anybody tell me what this is? And I know you know, Miss King. Okay, so this is a TARDIS, but does anybody know what TARDIS stands for?
Time and relative dimensions in space.
Well done, yes.
Waste my time. They're all doing that.
Time and relative dimension in space. And the reason I put that there is because that beautifully illustrates what four-dimensional radiotherapy is. So what we do is we want a way of seeing how the tumour moves in time and space. So not just the snapshot of the day that the patient comes for the CT, radiotherapy planning CT on the day. We need to know how the tumour is moving over some breathing cycles. And the way we do this is that we have an external surrogate on the patient, which we use as a marker of respiration. And then we take a CT scan over 2 or 3 breathing cycles, and we make a respiratory trace that you can see at the bottom of the screen that's individualized to that patient based on the external surrogate. And then we can, through a reconstruction algorithm, put the projected data bits of the CT back into the correct place in the breathing cycle, and that's called retrospective binning. And what you end up with is a moving image. And so what we can do is actually outline a moving image, so we know what's happening to tumour and how it's moving through the respiratory cycle. So that's great. You've got this fantastic plan that you've divided individual patient based on a 4D scan. You know how they're breathing. Fabulous. But how do you know when they come for their treatment that they're breathing in the same way, that nothing's changed? It's certainly possible that when they come for their first treatment, which is a week later or 3 or 4 days later, things may have changed again. So, and also even during the treatment, because stereoablative radiotherapy takes about 30 or 40 minutes to administer, there may be changes in respiration during the treatment. So we need a mechanism to assess inter and intra-fraction variation. And the way we do that is with something called Conebeam CT. So these are the new generation of linear accelerators or radiotherapy machines that we have, and they have Conebeam CT attachments. This one's a kilovoltage Conebeam CT, and you can have megavoltage Conebeam CTs as well. And what it enables you to do is to take a CT it's a low-dose CT of the patient while they're in the treatment position just before you're going to treat, and even during the treatment. So you can stop halfway through, do a cone beam, and then restart the treatment again. And then what that enables you to do is to overlay your radiotherapy planning CT, the Conebeam CT of the day on top of your radiotherapy planning CT, and then you can make any changes that you need to make to ensure that the tumour is in the correct position, and you're treating the dose that you want to go to the tumour is going to the tumour and nowhere else. And we've also got some 4D Conebeam technology as well that's recently been available, so we can look at 4D Conebeam as well as the 4D planning CT. So these are the practicalities of the treatment. The patient has to be reasonably fit. I mean, we say that they're medically inoperable, but they still have to be fit for radiotherapy. So they have to be able to lie in a treatment position like this with their arms up for around about 20 to 30 minutes. Again, there are new technologies that are coming available, such as arc radiation technology, that will enable us to reduce the treatment time, but certainly for our centre at the moment, it's taking about 30 minutes or so for each treatment. So this is one of the patients that we treated with a tumour, as you can see, and this is the plan. So as I say, it is basically a fan-like distribution of beams going all the way around the patient, but very small contributions from each beam, which is why you can afford to do this without damaging the rest of their lungs. And what we also do is we have to outline a whole load of normal tissue structures, so that's what I've highlighted over on the left side of your screen, because we need to know what dose not only the tumour is getting, but all of the pertinent normal tissue structures around the area. And the graphical data that you can see at the bottom of the screen are dose volume histograms. So we look at the dose comparing it to the volume either of tumour or normal tissue structure for each patient, so that we know exactly what is being treated. So certainly that's one way of treating, with a conventional linear accelerator. So you can certainly deliver this treatment with linear accelerators. This is the new kid on the block. This is the SABR knife, which you may have heard of. So all it is a linear accelerator on a robotic arm. So here, you can't see the arrow, but just that thing there is the linear accelerator, and it's on an arm, and it can basically move around in lots of different directions. So where with a linear accelerator you're a little bit limited as to where the beams can come in from, with this you can move it in any direction you like. And also, because you can move it in any direction you like, you can even make it breathe with the tumour. So if the dodgy movie works, I don't think it will. But anyway, this was basically, this was going to show you, it was going to move around and show you what it does. So it takes external images of the patient, and also you have internal fiducials inside the tumour, which you can take CT images of. The data is constantly being uploaded into the head of the LINAC, and what actually happens is you can actually see that the linear accelerator moves as the patient's tumour moves. So it truly is targeted radiotherapy. Because this has been, up to now, mainly in the private sector, we haven't had great clinical trial evidence to say that this is any better than standard linear accelerator-based treatment. But I think we are now getting a few SABR knives in the NHS, so I'm hoping that we're going to get a lot more clinical trial data, and it's very cool. It's a very good toy to play with. Okay. And that's made it crash now. Here we go. So just to say what we've done at GSTT, we treated 80 patients so far. We've analysed our data on 64, and the median follow-up is 9.8 months. So again, quite modest median follow-ups. We had 1 local failure, 4 regional failures, and 1 distant relapse. Local control rate is 97%. The overall disease-free progression rate is 86%. 1-year overall survival 92%, and 1-year disease-free survival is 89%. So if you can remember the first table that I showed you, really quite similar figures to what's in the literature. The other thing that we need to think about with SABR is toxicity. So I have to say that actually the treatment is very well tolerated, and I think it's tolerated better than conventional radiotherapy. There are reports of chest wall toxicity, including rib fractures. The pneumonitis rate is low with this compared to conventional radiotherapy. Esophagitis does occur, and fatigue. But as with our data, we haven't noted any early grade 3 or 4 toxicities, and only 2% late grade 3 toxicity, and no late grade 4 toxicity. So again, very well tolerated. So what I would say is that radiotherapy has come a long way. We've gone from 1950 something or the other, where I think that was probably a live source of radiation, and unfortunately the poor chap with a cancer on his neck is getting quite a high dose, but Charlie Chaplin and Dr. Kildare there are also getting quite a high dose of radiation. So we don't do things like that anymore, and this is the sort of thing that we're moving towards. But I would say that we still have a long way to go, and the way that the trials and research is going with SBRT is getting experience in treating more central tumours safely, combining SABR with other treatments such as chemotherapy or biological agents. Monitoring of long-term toxicity, I think, is very important, and trials to compare SABR with surgery. So there are a couple of trials that are running at the moment. One is Hiran Fernando's trial, which is a phase 2 in America, phase 2 randomized control trial looking at sublobar resection with or without brachytherapy versus SBRT in stage 1 non-small cell lung cancer. I think it's quite a complicated trial because you're looking at too many things, but it'll be interesting to see what that shows. And there's also a trial in the Mayo Clinic looking at SBRT versus sublobar resection. So I think really the evidence will tell us in the future. And that's all I have to say. Thank you very much.
Thank you very much.
Okay. Just minimise that.
I got one question, Sharina.
Yes.
Okay. I enjoyed your talk very much. My worry about this in Britain, as we're introducing this, is pathological confirmation rate. And we have arguments with us all the time at Cambridge.
Yeah.
In Holland, the pathological confirmation rate is about 30%.
Yes.
And they've done more than anyone else in Europe. In America, it's close to 100%.
Yes.
For a number of reasons, including more granular disease, also including medical legal situations. I think we have too many cowardly radiologists who don't want to do it. But my feeling is we shouldn't really be doing this unless we can get histological or psychological confirmation.
Yes. Yeah, no, I would entirely agree with you. And certainly that's the practice that we have at our centre. And I think we're very lucky in that our radiologists are very good. And to a certain extent, we also try and get e-buses on as many of these patients as we can. So if there is any worry on the PET scan that there may be nodal, reactive disease in the nodes, they will get an e-bus as well. Because I think that's the other argument against SABR and non-surgical treatments is that you don't adequately stage the mediastinum prior to treatment.
I think that's absolutely right, but it's also important that when you're assessing the overall toxicity of stereotactic radiotherapy versus surgery, you have to include the toxicity of the percutaneous biopsy, because usually that versus going straight to an operation. But I'm heartened to hear that your tissue diagnosis.
I think it's really important. We see a difference in different referring hospitals.
Seems like a make.
That one down.
So Mr. Barnard's going to tell us about the current state of surgery for such patients and some early comparisons against stereotactic radiotherapy.
When this thing works. You can't even get off that.
Come through from the spirit world.
I'm trying to load this. Sorry? That's this one here. One with 13 on it, yeah. It's not letting me do it, is it? It seems to have this blue thing came up. Still on something else. So where did the body come from? That's it. Okay. Great. Thanks very much. Well, good afternoon, everybody. I'm going to try and talk about. I was set by Mike 3 or 4 weeks ago to replace Dave Waller, which is obviously something I can't do, on this talk on limited resection in poor lung function. In setting of poor lung function, and I'll touch on SABR and some of the points that have already been raised towards the end of the talk. It's interesting that this actually is confined to a small subgroup, which is well defined, and I will define it and go through some of the data that we now have to tell us what we should be doing with these patients. So what is a limited resection? It's any resection that's less than a lobectomy, essentially. That includes segmentectomy, more than one segment, because often segmentectomy includes 2 segments, or a wedge resection. And segmentectomy itself is an operation we think about as has only been around the last 10 or 15 years. But in fact, there's a whole book which a nerd like me has found and bought from the 40s, which described all the segmentectomies, because it was an operation that was done for TB and bronchiectasis. And I think limited resection, the evidence I'll present suggests that we should only be thinking about limited resection in stage 1A, in T1A tumours, that's tumours less than 2 centimetres. And of all cases that are presented to us in MDTs, perhaps only 5% will be this T1E group of tumours. Having said that, limited resection is common. This is data, most up-to-date data we've got from the Society database, and draw your attention to the blue wedge there with the 603 on. This is from 1 year's worth of data for resections. Obviously the commonest operation is a conventional lobectomy, 3323, but 603 of all the operations done for lung cancer in the UK in that year, 12.8%, which is more than 1 in 8, were a wedge resection or a segmentectomy. It's not possible to drill down on the data and say how many had wedge, how many had segment. So it is a common operation. Why limited resection? Why not just do a lobectomy? Well, we extend the surgical options in the borderline fitness patient, which is the group we're talking about today. We preserve lung function, we think. It's not as because we're leaving lung behind and not perhaps doing it quicker, it's less morbidity and mortality than lobectomy. And we can potentially offer further surgery in case of a second new primary, or if the patient is unfortunate enough to have synchronous primaries when they present. And second new primary is a big problem. It's 1 to 2% a year from the various series, and in this month's JTCVS, there's a series from the Mayo of patients who've had surgery for metachronous lung cancer with a 60% 5-year survival. So we know what a limited resection is now, that's defined, and we know who should have it, that's people with T1A tumours. What's poor lung function? We talked about this before with Simon's talk at the beginning of the afternoon, and the 2001 BTS guidelines suggested post-operative FEV1 less than 40%. Certainly when I started as a consultant in 2000, these were useful lines in the sand to draw, beyond which you only stepped over when you thought that the figure was at variance with the performance status, or if you're feeling particularly bold. But many people felt that this was too low, and the guidelines published a year or two ago by Brunelli in the European Respiratory Society suggest that less than 30% is the real poor lung function. This is post-operative predicted. And I would argue that it's somewhere between 30% and 40% post-operative predicted is where the poor lung function patient lies. You could make the same argument for transfer factor. In fact, I would probably say transfer factor is more sensitive than FEV1, but again, you come down by a similar argument to 30 to 40% post-operative predicted, and certainly anybody who's borderline should not be written off for surgery or SABR or any other type of treatment unless you've got at least one other pulmonary function test to corroborate that. I'm not clear about the role of CPET. We're told that the Europeans are doing it on everybody. I don't know how we assess the prediction with CPET, particularly when you're planning a limited resection, which is the subject of this talk. Certainly they should be PS2 or lower. I don't think anyone would advocate doing patients of PS3 or 4. A wedge resection, for people who don't know what a wedge resection is, I'm sure everyone does. It's been reserved, and I suspect this is what most of these ones, 600 that are done a year here, are wedge resections with staplers, very simple operation. A monkey could do this operation, and I think the problem is because it is so simple, it's probably been overused. That's what you get when you've done a wedge resection and linear staple line. Job done. It takes longer to open and close the chest if you're doing it open than it does to take this thing out. Segmentectomy, as I say, is a classic operation. This is the book, Overholt and Langer, 1949. The patient would be prone, and then described all the segmentectomies. 10 on the right, 8 on the left were described. Technically demanding, it was them in those days. It's probably a bit easier now with staplers and things. The question is, should we be doing a segmentectomy? Should we do a lobe? And this book has just come out. It was due out at the end of January, delayed, but I bought it, and it's on the way, so it actually is available. It's about £100. It's got all the segmentectomies described, and this is one of those things you can look on with Amazon. You can go in and have a look at the book, and this is a picture from it, and just shows you how complicated it is to do a proper segmentectomy. This is left upper lobe trisegmentectomy, so leave the lingula behind, and it's showing you all the little fine vessels, and you can see how some surgeons say, oh, just take the lobe out. But I can't be the only surgeon in this room who, when you're doing a lobectomy for a small sized tumour, and you're pulling the lobe out, big lobe coming out at the end of your hand, you've got a tiny little tumour that you've identified at the beginning, and you think, am I overdoing this? Have I really done this patient a bad turn today by taking this out? And you can convince yourself and say, well, we've got good clearance now. Conversely, if you do a limited resection, I've done some of these segmentectomies, you think as you're pulling the little segments out, this little farty bit of lung coming out, well, have I done enough? Should I have done a lobectomy? What are the size limits? But we are finding some data. And the classic, this is one of the few trials that every thoracic surgeon should know, and I'm always stunned when some people who sit well into their training don't know this trial. I know it's from 20 odd years ago, but it's a randomized trial of 240 patients looking at segmentectomy or wedge resection versus lobectomy for what was then T1 tumours. And there were no survival differences in the two groups. There's a higher recurrence rate in the limited group, which showed some improvement in lung function, which at a year was eliminated. So the standard of care became that lobectomy was the better treatment for small lung tumours. And then about 5 or 6 years after that came out, a Japanese group led by Okada started publishing data on lobectomy versus segmentectomy, not randomised, and has shown good results with limited resection of small tumours. And he showed that in a series of a number of patients over 15 years, 7% of all the lung cancers that were looked at in the IASLC, so that's about the number we might see in an MDT, might go up with screening. His study looked at 140 lobectomy patients from a retrospective group versus 70 prospectively collected segmentectomy patients, and got 87% 5-year survival in both groups. This is obviously 2 centimetre tumours or less. Another group published the same year as Okada's first report showed that even these small tumours can have metastasis. If it's adenocarcinoma, small adenocarcinoma can have nodal metastasis. That's N1 or N2 disease. So that's something to be kept in mind, that these aren't just always T1A. They may be T1A, N1 or T1A, N2 in up to 20% of cases and more sometimes. This is just to reinforce that the size is important here. Anything bigger than 2, and we start to move out from where segmentectomy is worthwhile. We move back into the lobectomy bed, and we should abandon limited resection. So the Bando study, which is actually really a technical way of how to do a segmentectomy, actually reported on 74 patients with a 93% 5-year survival, much better than, well, a little bit better than Okada's data. But once the tumour started to be a bit bigger than that, the 5-year survival dropped quite a lot, and the local recurrence rate went sky high. If you had a small tumour, local recurrence for the little tumours less than 2 centimetres, the T1As in other words, very low, an acceptable rate of local recurrence. However, by only having a centimetre greater diameter, pushing on towards 3 centimetres, the recurrence rate became unacceptably high at 33% with segmentectomy. Now there is a phase 3 trial of lobectomy versus wedge or segmentectomy for less than 2 centimetres, this group I'm talking about. Open or VATS is available, and when I last looked at this a month or two ago, they were about a quarter, a bit more randomised, and they think they will complete in about 5 or 6 years' time. So we have to wait for that to tell us whether lobectomy or segmentectomy is best for these T1A tumours, but that data will come out. The Japanese are running a similar trial of lobectomy versus segmentectomy for less than 2 centimetres again, open or VATS, better recruitment, and may have some data a couple of years earlier than the American study. So from 2 phase 3 trials, we will know perhaps at the end of this decade whether segmentectomy is favourable for small tumours. Just to divide limited resection for a second into wedge or segment, because there is some data out there on wedge or segmentectomy. If you looked at the segmentectomy data, Miller's data on a small number of patients, wedge resection is clearly an inferior operation compared to segmentectomy. It's easier to do, but it doesn't give us good results. And the bigger series are showing significant 5-year survivals with segmentectomy, but inferior with wedge resection. Still quite good from the El Sharif group, 86% with 5-year survival with wedge, but other groups have reported more inferior results. But let's go back to SABR. How can surgery stack up with SABR? It's sexy. It's laser type stuff. It's a big machine that costs millions of pounds. It's radiotherapy nurses wandering around in white stuff and all that stuff. And what have we got? grey-haired surgeons with a knife and a staple gun as our most... that's all we've got. So obviously people who want to go for SABR. This is Rob Timmerman with a blue SABR. See? And he has written a paper recently about the role of SABR, and I'll come to that in a second. So there are data starting to come through about SABR versus resection. Obviously, there are historical data, which I won't go into, but in too much detail. But in the Journal of Thoracic Oncology last month, there was an interesting paper looking at how both types of treatment fail. Whether you have this is not sublobar resection, this is lobectomy or pneumonectomy versus SABR. The SABR group, as you would expect, is less fit because they're not fit for surgery, and of course because a number of patients in the operative group had nodal dissection, some of them went on to have chemotherapy. So if you like, the SABR group were fighting with an arm tied behind their back compared to surgery. But both treatments, surgery or SABR, had good local control. Look at the overall survival. At 4 years of the overall survival was 63% for resection and 30% for SABR. And that persisted when they did a propensity matching between the two groups for tumour size. Now, in this month's JTCVS is an interesting, I had to read it 3 or 4 times to get my head around it, but it's basically an analysis by the Washington group of 2 other trials which have been running. The RTOG 0236 is a SABR trial only, as far as I can see. I couldn't work out what it was a trial against. I think it's just SABR, just the patients have SABR. And the American College of Surgical Oncology Group 4032 is a trial of sublobar resection with or without brachytherapy. And so from the database of these patients, which have a lot of lung function, post-treatment lung functions and things like that, the data was exported to Washington and it was analysed. There isn't as many in the group of SABR versus the sublobar, but they were able to use these two. These are 2 different trials, but they've taken the data from both of these trials, pre and post-treatment, to work out what's going on. And I've drawn a histogram from it. The SBRT treated patients were fitter. This is in contradistinction to the Robinson paper last month. They were fitter patients, and before their lung function before and after, this is FEV1, it was reduced from 65%, which we would say bargain in a Newcastle patient to have 65%. I'd be running and hugging him and everything. But post SBRT, the lung function was down to 55-56%. The segmentectomy patients from the other study, when they had the FEV1 compared before the segmentectomy and after the segmentectomy, actually the FEV1 went up a little bit. So, surgery improves you. This is the sort of lung volume reduction effect, possibly. So you might say, okay, let's go to transfer factor, my other favourite lung function test. And again, SBRT, they were fitter patients in terms of transfer factor. And again, there was a reduction in transfer factor in the SBRT treated patients. But the segmentectomy patients actually improved. It's all a bonus. Others have looked at pulmonary function when going back to lobectomy versus segmentectomy argument, and they looked at pulmonary function a year from operation. And it dropped. We know that the postoperative predictive FEV1 actually doesn't occur. It doesn't go down as low as what the POP FEV1 says. What they actually found was the decrease was about 8% for after lobectomy and about 10% in transfer factor, again after lobectomy. In segmentectomy, because it's taking less lung away, showed no change in FEV1 and the transfer factor down 12%. And the Okada unit looked at, again, the lung function in lobe versus segmentectomy, and also the Bruce protocol exercise test, and they showed that segmentectomy is superior to lobectomy, about 5 to 10% absolute, and these are the figures from their paper, showing segmentectomy is a better preserver of lung function, as we would suspect. Now, randomized trials are obviously the way that this is going to be sorted out, but the Dutch group have already tried this, a randomized trial from about 5 years ago of resection in small-sized tumours versus SABR, maybe not such a high dose, 60 gray was to be given, and they were aiming for 960 patients, and it closed early because they could only recruit 51 after 2 or 3 years. So just because we think the patients should be randomised, we may not get enough. As I say, there are perhaps only 5% of all the tumours that are offered to us per year. the Dutch group was less than 2 centimetres, which is becoming the cut-off, I think, for these trials, and they said wedge resection would not be allowed, and I think that's good. I'm not sure how, if you're going to do a trial, how SABR sits with the fact that in the surgical group will be upstage in about 30%. We know this. But there is a trial that's recruiting. This is the Z4099 trial. It's surgery plus or minus brachytherapy to the because it's sublobar resection, and you can leave, I think, some local radioactive things in the staple line or something to try and give you some local radiotherapy along with your surgery versus SABR in a high-risk patient. And that's accruing, and I'm not sure how that's only just started as far as I know. So in summary, segmentectomy, but not wedge resection, may be an alternative for tumours of less than 2 centimetres. After that, in terms of size, i.e. 2 centimetres plus, we need to go to lobectomy. It preserves lung function well, and in fact in recent trials it perhaps doesn't make much difference at all to lung function, and it is a possible standard of care for T1A tumours, but patients should be entered into a trial versus SABR. Thanks.
Thank you very much, Sean, particularly for underlining what's becoming increasingly apparent to me, that segmentectomy is an operation that we're all going to have to learn how to do again in a way we haven't really done as a group for a few decades, and I'm certainly going to be buying the Japanese book tomorrow. Can I have a show of hands? Who's done a segmentectomy in the last month of the independent sessions? Last 6 months? Who's done a VAT segmentectomy in the last 6 months? I hope that'll be a different story in 2 or 3 years' time. We're going to compete with SABR. We're going to have to learn how to do this. Any questions for either of our speakers?
Can I just ask, Shireen, which patients do you think you should be seeing for consideration of SABR? If I've got a patient that I'm going to do a segmentectomy on because the lung function is poor, I'm going to be doing a wedge on, do you think you should be seeing that patient as well to at least offer them?
I mean, I think certainly, the evidence isn't there yet, so it would be useful if they wanted to have an alternative to surgery. There are certainly some patients who don't want to have an operation by choice, and I've had a few of those come to me, and they've had SABR. So, and if you can put them into a clinical trial, then that's the best thing to do, I think, at the moment.
Because I know my practice is anyone who I'm not going to do a lobectomy on, because I'm not happy to do, I will refer them, at least for an opinion, to see the oncologist to discuss SABR. If I'm going to do a lobectomy, I'll just get on and do it. So I think that's, but if it's anything less than that, then I'll at least give them the opportunity to speak to the oncologist. They don't know what everyone else does.
Well, I gave not quite the same talk, but I was focusing more on segmentectomy versus lobe in BTOG, and it got me thinking, it's changed my practice now. If I get a very small tumour, I think you will have to tell the patient that there are alternative treatments available. Now, obviously, once it gets above 2.53, you can go on and just do your lobectomy. That's absolutely fine. But you can say there are alternative treatments. They include conventional chemoradiotherapy, or what I call focused, radiotherapy, which is SBRT. And if you want to go and speak to somebody about that, we can do that and wait, and you can come back. And I think that's the best thing to do, because you could find yourself, if you get somebody, if either they get a recurrence or they die after the operation, the lawyer might say to you, what other treatments did you offer this patient? And if you said, well, I thought an operation, but the data's out there that this may be a good alternative to surgery.
Can I make another request of you? Who would agree to the statement that thoracic surgeons should not be offering wedge resection as a treatment for lung cancer?
Who would agree?
Yeah, so who thinks wedge resection should not be offered as a treatment for lung cancer?
I can remember the Ginsberg trial coming out. I've just been appointed as a consultant. It's a great trial because it was looking at staplers basically. Staplers would run rampant in the 1980s when they were invented. Everyone was having a wedge resection. It was quick. It was attractive. You didn't have to take the whole lobe out. And Ginsberg said, "Hang on a minute, this might not be right." And that trial was stopped early. You didn't mention that. It was stopped early because the trend to poorer survival was there for wedge resection. So it was obviously a poorer treatment. However, given the fact that we're trying to help people with lung cancer, we turn them down for surgery. If only the only thing we can do is a wedge resection, say, let alone a segmentectomy. Because you're worried about these patients, don't you? They've all got emphysema, they've all got bronchitis. You don't want to kill them. The SBRT that's coming now is an alternative to wedge resection, obviously, isn't it, as I see it? And if you can do a lobectomy, you should do a lobectomy. Maybe a segmentectomy. If, as you say, you've got a huge rate lobe, little tumour in it, with a segmentectomy. It's no more difficult than a lobectomy. You can do a lobectomy, do a segmentectomy, I'm sure of that. But these patients, I see that we're getting more and more of. We should give them a chance to see someone actually, and Joe, who's got this new technology, which may well be better than a surgical wedge resection. That's why you wanted that vote, isn't it?
I guess that's what I was
Because you
trying to
don't like wedge resections. I agree with you. It's the best we've got at the moment, but we still do it, and that's why no one will put their hand up. But
If the patient is fit for a wedge, I guess my proposal would be that they're also fit for a segmentectomy, but none of us know how to deliver that thoracoscopically with local digital.
Question there?
In view of local recurrence and in view of decreased survival in patients who go for sublobar resection when they are not fit for lobar resection, do you think we should be pushing towards adjuvant therapy, chemotherapy after the sublobar?
No, well, I mean, that statement is pretty sweeping because what the data presented is that in the correct patient, that is less than 2 centimetre tumour, the treatment should be segmentectomy because that has a low risk of local recurrence and a high chance from at least 2 different studies of curing the patient, of being here at 5 years. There is this study going on that in limited resection, that maybe at the end of the procedure you maybe should add in some brachytherapy to decrease the chance of local recurrence, and we'll have to wait for that 032 study to come out to tell us whether we should be adding something to the segmentectomy or not. But the segmentectomy results from 10 years ago from Okada's unit, survival is very high, local recurrence is very low, so long as it's less than 2 centimetres. And you get the higher recurrence when you start to put up the size and you still limit your resection. I think once it goes over 2 centimetres, the data is absolutely clear. You should be doing a lobectomy, full stop.
Got time for just a couple more questions. Are there any more questions? Sorry, Joe.
Just a couple of general ones. I mean, brachytherapy gets much more difficult as you go more peripheral in the lung. And, peripheral tumours after segmentation, you probably wouldn't be able to do it. But I thought your point about transfer factor was really interesting. Maybe that's something you should come into what you're thinking about. It's reasonable to think that if you remove it surgically with a small margin, a piece of lung that isn't contributing, then it's logical to think that transfer factor might well improve a bit. Radiotherapy will always drop your transfer factor to some degree. And one of the things we're thinking of is how much can this patient afford to drop the transfer factor depending on where it's starting off from.
Yeah.
I think that's an important point that people probably haven't talked about enough so far.
Is there a general agreement amongst clinical oncologists from the country about SBRT that you would not consider it if you don't have a definite histology? Is there a kind of?
Oh no, we advise about it every week.
We've talked about it, but I just don't take no for an answer.
That's
They
great.
have to have this knowledge.
We have people from different hospitals and they come to our meeting and I say, well, what's the histology? And my colleagues say, well, we don't have it because they won't do it. And I say, well, tell them you won't do this then.
People are getting metabolic biopsy, which
Which is nonsense, you can get, everyone can show slides where you've got a bit of PET scan that looks just like cancer, and actually isn't. I mean, I think you're doing really well to have a high rate. Ours, even with nutrition, is only about 50%. And Holland is, Holland is 30.
Yeah.
Holland is tight in with it. And we're getting lots of patients referred in from other centres outside, where they just haven't really any attempt to histology at all. And they've kind of semi-promised patient treatment.
And then I think what we do then is we get our radiologists, because I have to say we're very lucky that we've got very good interventional radiologists who will...
young thrusting chaps who haven't had much morbidity yet.
So when they come in from outside, we'll get our interventional radiologists to do.
Well, our problem is that sometimes our guys are too busy to do that. We can't give them a big load. But in America, the radiologist realize that if they can lie on their back, they can do a percutaneous biopsy. That's the test they do.
Okay, thank you very much to the speakers, especially